Well, good morning, all of you, and good afternoon and good evening to all others who are joining from rest part of the world. Sorry for the delay because of some network issues here. Today, our guest speaker for the day is Dr. Lena Speck from Denmark, and she's going to lecture us on palliative radiotherapy in hemato-oncology. This webinar is brought to you by Mumbai Hematology Group, supported by Adlai and managed by Perfect Square. I thank Mr. Ashutosh Shukla and team from Adlai, Mr. Yash, Mr. Kalpesh and the team Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest for the day, Colonel Dr. Rajiv Kumar from Delhi, our guest speaker for the day, Dr. Lena Speck from Denmark, all our discussants who are themselves very eminent hematologists as well as hemato-oncologists, and you participants for sparing your Sunday morning, afternoon or evening from whichever part of the world you're logged in. Let me give a flavor of our next weekend activities. Next Saturday, that is 6th of July 2024, from 7 p.m. Indian Standard Time and 6:30 a.m. US Pacific Time, we have Professor Naresh Kikri from Washington, US, speaking to us on how to diagnose lymphomas presenting as splenomegaly by peripheral blood and bone marrow studies. And the following day, that is Sunday, 7th of July 2024, from 11:30 a.m. Indian Standard Time and 8 a.m. Polish time, we have Dr. Wojciech Zudzak from Poland speaking to us on how do I manage newly diagnosed DLBCL in 2024. Let me introduce our discussions for the day, and we have a galaxy of them here displayed in alphabetical order. To start with, we have Dr. Akanksha Garg from Zydus Hospitals and Zydus Cancer Center, Ahmedabad, Dr. Amber Garg from DKS Hospital, Raipur, Dr. Anupam Jaggia from NHS Trust, London, Dr. Anurag Kantak from IRCH AIMS, Delhi, Dr. Arya Pradhan from GCRA, Ahmedabad, Dr. Asif Iqbal from Dr. Barua Cancer Institute, Guwahati, Assam, Dr. Avriti Baweja from Himalayan Institute of Medical Sciences, HIMS, Dehradun, Dr. Darshan Kanani from Goa Medical College, Goa, Dr. Darshana Rane from Wockhardt Hospital and Raija Hospital, Mumbai, Dr. Deepali Borade from Apollo Cancer Center, Navi Mumbai, Dr. Dipanjan Haldar from Jupiter Hospital, Thane, Mumbai, Dr. Divya Narayanan from Mazumdar Show Medical Center, Bangalore, Dr. Du Yuen Naga from Vietnam National Academic Cancer Hospital, Vietnam, Dr. Gopinathan M from MGM Healthcare, Chennai, Dr. K. Sudhir Reddy from Omega Hospitals, Kurnool, Andhra Pradesh, Dr. Karan Sood from Jawaharlal Nehru Medical College, Wardha, Dr. Malikarjun Kalashetty from Comprehensive Cancer Center, Manipal Hospital, Bangalore, Dr. Mona Vijayaran from SGPJ, Lucknow, Dr. Monica Chennareddy from Vaidehi Hospital and Research Center, Bangalore, Dr. Muhammad Rifai from Government Medical College, Calicut, Kerala, Dr. Mulidharan C from Wockhardt Hospitals, Mumbai, Dr. Nishad Dakate from HCG NCHRI Cancer Center, Nagpur, Dr. Pooja Prasad from Homi Baba Cancer Hospital and Research Center, Punjab, Dr. Prashanta Bhatt from KMC Hospital, Mangaluru, Dr. Raghavendra Rajeshwarkar from Solapur Cancer Center, Solapur, Dr. Roshni Pandey from Mahakaushal Hospital, Jabalpur, Dr. Sangeeta Kakoti from Tata Memorial Center, Mumbai, Dr. Satish Kumar A from Manipal Hospital, Yashwantpur, Bangalore, Dr. Smita Kayal from Jawaharlal Institute of Postgraduate Medical Education and Research Center, Jipmar, Pondicherry, Dr. Suprakash Sanyal from Fortis Hospital, Mumbai, Dr. Sumit Merik from Tata Memorial Center, Actrac, Mumbai, Dr. Sunit Lokwani from Kokilaben Dhirubhai Ambani Hospital, Indore, Dr. Yashwant Kashyap from AIMS, Raipur. Now it's a time to introduce our special guest and chief guest for the day. We have with us Colonel Dr. Rajiv Kumar from Delhi. Colonel Dr. Rajiv Kumar is Senior Advisor in Medicine and Clinical Hematologist at R&R Army Hospital, Delhi. It's my privilege to invite Colonel Dr. Rajiv Kumar to inaugurate our webinar and give some words of wisdom. Over to you, Colonel Dr. Rajiv Kumar.
Am I visible?
Yes, sir. Please go ahead, sir.
Thank you, Dr. Amit. And dear friends, it's a matter of great honor for me to be invited as a chief guest on this academic forum. I thank MHG for this honor. And to all the hematology residents and junior colleagues attending this webinar, I would like to quote Professor Victor Hofbrand to start with. I have hopefully conveyed to readers of my textbooks my firm belief that hematology is the most exciting clinical and research discipline within the broad field of medicine. And I totally agree with that. The journey from internal medicine or pediatrics to hematology is a difficult one because it involves a different kind of mental approach. And as for any other super specialty, the road to learning and getting some level of expertise is a very long one. And I believe that the key to this journey is daily regular reading and observing your patients very cleanly. You all will agree that the frantic pace of research in this field of hematology is very exciting, but at the same time, it threatens to make our knowledge outdated before we even realize that. Hence, it becomes very important that we keep learning all the time and utilize all the resources to keep ourselves up to date. The other point that I want to make today is about research. It is very important today than ever then that we get into genuine research and make it an institutional practice wherever we are. Research is not about accumulating too many publications. And in my opinion, it is just about addressing the very basic and small questions that we face in our clinical practice or clinical life. And also, we need to search for answers for the problems which affects our populations. And many of the answers which are there in the Western literature may not be applicable to us in its entirety. And there are innumerable such questions, some basic questions like even megaloblastic in Indian population, which is like an epidemic, and a lot of questions are unanswered. So it is very important that our data is genuine and clean, and so that we can reach some kind of meaningful conclusion. And clinical inquisitiveness is the seed for such original research. Also, today I'd like to exhort you all to make teaching a way of your life in your daily clinical curriculum. Wherever you are, in whatever capacity, is very important to teach the nurses, the paramedics, the medicine and pediatric JRs, the medical officers, junior colleagues, and try to maintain a very strong academic environment. We all know that teaching is one of the best ways of self-learning and improving. And finally, I would all request you to go deeper into drug-related research publications before you decide to use it in your patients. The ever-increasing cost of therapy in hematology is a major issue today for our patients, and the pharma pressure is also relentless. We have a lot of sponsored speakers today who tend to highlight only the positive aspects of the drug and its publication. So it is important to read between the lines and also keep a keen eye on the patient when using newer drugs, with which we may not be very familiar with. It is always not necessary that we learn only when we have made a mistake or a patient suffers from an avoidable side effect. So with this, I wish you all a very fruitful journey in this exciting field of hematology. And once again, thank MHG for inviting me to this forum. Some exciting talks and discussions on radiotherapy is coming up. So let's enjoy this academic feast.
Thank you, Colonel Dr. Rajakumar, for that wonderful, kind words of wisdom. Thank you for joining us as our chief guest for the day today. Thanks a lot. Let me share the screen again. Now it's a time to introduce our guest speaker for the day. We have with us Dr. Lena Specht from Denmark. Dr. Lena Specht is Professor of Oncology at University of Copenhagen, Denmark. She completed a training in clinical oncology at the University Hospital in Copenhagen and holds a European certification in medical oncology from ESMO. She obtained her PhD degree with work on prognostic factors in Hodgkin's lymphoma. She is a chief oncologist at the Department of Oncology at Rigshospitalet, the University of Copenhagen. Her main areas of research and clinical interest are lymphomas as well as head and neck cancers. She is the author of over 310 research articles and educational papers, including ESMO guidelines on peripheral T-cell lymphomas, cutaneous lymphomas, and CNS lymphomas. She has authored 3 textbooks and numerous book chapters. She has an H index of 77 with over 28,000 citations. She has supervised 18 PhD projects and numerous postdoctoral, postgraduate, and pre-graduate projects. She is the editor of Cochrane Hematology Group and member of advisory board for Acta Oncologica and UICC TNM expert panel for lymphomas. She is also the past chairman of the Danish Hodgkin's Lymphoma Group, chairman of the Radiation Oncology Committee of the Danish Lymphoma Group, and vice president of the International Lymphoma Radiation Oncology Group. She has been scientific evaluator for Cancer Research UK, the Swedish Research Council, the Swiss Cancer League, the Swedish Cancer Society, and the Wellcome Trust. She received the annual prize for the Danish Society of Clinical Oncology in 2004 and the ASTRO, that is European Society for Radiotherapy and Oncology, Lifetime Achievement Award in 2022. And today she is with us and she's going to lecture us on palliative radiotherapy in hemato-oncology. Well, thank you so much. Over to you, Professor Dr. Lena Specht.
Radiotherapy in hemato-oncology, and I'm very pleased that you want to hear this subject, because I realize most of you are medical oncologists or hematologists, and I'm a clinical oncologist, so I do both modalities, and I've a special focus on radiation therapy in hematological malignancies. And this is for you another specialty, but I think it's a very important one, because the palliative treatment of hematological cancer patients is really an important subject, and it may be underused, because you will need to collaborate closely with your radiation oncologist locally to exploit this potent modality fully. And the next slide is just to know my. Am I not able to control this? And next slide. Do I have to ask you to forward the slides, because it doesn't seem to happen when I do it? You can control your screen. What view options? Could you forward? Thank you. So palliative radiotherapy in lymphomas, leukemias, and multiple myeloma is a sort of a special area, because in some patients with recurrent or refractory hematologic malignancies may still achieve complete remissions and long-lasting remissions, especially with some of the newer agents. And this may, to the responsible physician, blur the line of transition from curative to palliative treatment to a larger extent than is happening in the solid tumors. It may introduce some prognostic uncertainty and may cause delays in goals of care discussions. It may lead to lower rates of hospice use, and it may lead to a more aggressive care at the end of life, which may not in the long run be in the patient's interest. So I think in hematologic oncology, we need probably to focus a little more on when is the patient actually transgressing into a palliative phase of the disease. And most hematological malignancies are radio-responsive, even in the relapsed or refractory setting. In fact, what I want to remind you is that despite all the new drugs and fantastic developments there have been, radiation therapy remains the most potent tool for obtaining local control in most hematological malignancies. So radiotherapy is an important tool for alleviating symptoms. Surgery is rarely needed in the hematological malignancies, because relatively low radiation doses and relatively low number of fractions, that is, single treatments, are needed. So this is the classical kind of palliative situation, but increasingly radiotherapy is used also as a bridging while waiting for new systemic treatments. And in this situation, again, we want to move to fewer fractions, which, given the time constraints, would be ideal. And also to realize that the actual complete local control may be less important, because some other systemic agent is to be introduced to this patient. So it's just a matter of keeping the disease at bay while waiting for instance, CAR T cells. And also increasingly that radiation therapy is used not just for bridging, but for debulking with new immune treatments, because it has been shown, for instance, for CAR T cell therapy, that the result of the treatment is better if the tumor burden is low. and also that probably some of the side effects like cytokine release syndromes or ICANS may be less severe if the tumor burden is low. When we are using radiation therapy as a palliative measure, the goals are different and the techniques are modified accordingly. When we are doing palliative radiotherapy, we only want to irradiate the gross tumor volume that is actually giving the patient these symptoms. So it is treated and that is important to be able to limit the radiation volume and therefore the toxicity of the treatment. You can see here on the left, on the right, a patient with a large diffuse large B-cell lymphoma recurring in the maxillary sinus with destruction of the bony structures. And this is a fast-growing tumor. So in that situation, I want to irradiate the gross tumor volume, which is shown in pink, but I do add a slight little margin because I know that will be a couple of days from contouring to treatment. So I will have to allow for the fact that the tumor will be growing, so I might add a limited margin, but otherwise the volume that we are irradiating is limited because we are not trying to cure the patient, but just to alleviate the symptoms for this particular location. With regard to doses and fractionation, well, they're commonly extrapolated from those we are using in advanced solid tumors, for instance, 8 gray in 1 fraction, that is very short treatment, 20 to 25 gray in 5 fractions, or 30 gray in 10 fractions. The fractionation you need to understand in radiation therapy is the smaller fractions are important mainly for long-term toxicity. Now, obviously, if you're in a classical palliative situation, long-term toxicity is not an issue. So we don't need to use small fractions for that reason. But I'll get back to why we may even be freer today than we were in the past to use fewer but larger fractions. So these are the fairly modest doses, and they are quite sufficient for hematologic malignancies in most cases, as hematologic malignancies are generally very radiosensitive. In patients with a relatively good life expectancy and performance status, higher doses may be considered, for instance, 36 to 39 gray in 12 to 13 fractions. The 36 gray is the normal upper limit for curative treatment in Hodgkin lymphoma, and 40 gray for aggressive non-Hodgkin lymphoma. In patients with hematologic malignancies, it's also important to know that the fraction size, it is important for long-term consequences of normal tissues, but the hematologic malignancies have very little or no repair or radiation damage, so there is no effect on the tumor effect by fractionation. So whatever fractionation you give, the total dose is what you are getting in your tumor cells, and there's not much difference between small and large fractions. So the only goal of hypofractionation, and hypofractionation means larger than normal fraction sizes, that is above the usual 2 gray. The goal of hypofractionation in hematologic malignancies is solely the reduction of treatment time. We're not getting any bigger tumor effect by that. And we had some interesting and valuable experience from this, actually from COVID. In the International Lymphoma Radiation Oncology Group, ILROG, we decided very early on in the COVID pandemic that we needed to make guidelines helping our colleagues around the world to deliver radiation therapy safely during the COVID pandemic. So we sat down, literally working day and night with people from all over the world, as you can see from the author panel, and made guidelines as to how we could act in the COVID pandemic, because we anticipated that there might be a reduction of treatment capacity if the staff fell ill. Wasn't fortunately the case in most places. and also a desire for minimizing the exposure of high-risk patients by limiting the number of visits to the clinic. So the solution that we proposed in this publication, which was incidentally, it was published in Blood, and it actually only took 3 weeks from we got the idea until it was accepted. So that's it was very urgent. And the proposed solution were, first of all, to omit radiotherapy in certain situations, to delay radiotherapy in certain situations, but also to shorten the radiotherapy course by using hypofractionation. And we did that. We made meticulous calculations from the radiobiological factors to make sort of translations from normal fractions to hypofractionated regimens, and we've used them the world over. And we have afterwards gathered data on the patients who were treated according to these hypofractionation schemes. And this has given us some very valuable experience with a concept that was never before used in hematologic malignancies because we were afraid of long-term side effects. And so what we have to remember is, however, that modern radiotherapy has changed immensely from what was done in the past. In the past, we only gave, we planned two-dimensionally. So and when we treated patients, we sort of gave the full dose all through the patient, and the amount of normal tissue treated to the prescribed dose was actually quite big. So in that situation, small fraction sizes were important to keep the risk of long-term complications as low as possible. But in the meantime, technology has changed, and today's radiation therapy is given in a much more conformal way. So with modern highly conformal techniques, only the lymphoma and the very close surrounding structures get the full dose, whereas most of the normal tissue that is lying between the tumor and the treatment regime actually gets a very small dose. And you can see this simplified here. This is the patient with a retroperitoneal residual lymphoma, and we are irradiating the tissue that contain or where the residual mass is, the positive mass is located. And with the modern technique, we're able to focus the radiation therapy so that it's only the lymphoma volume with a very tight margin that actually gets the full dose, whereas the surrounding normal tissues are irradiated, but to a much lower dose. They're out here in the green and blue areas. So this shows you what all the dose from 0 to 100%. Down here, you can see what happens if we look only at the tissue volume that gets more than 50% of the prescribed dose. And so you can see here that even if we prescribe a dose of not 2 gray, which is the normal fractionation, but of 4 gray, it will only be this volume that ever gets more than 2 gray fractions. So the modern technique in itself has made it much more possible for us to use larger fraction sizes, because the volume that actually gets the larger fraction size is so much smaller. And you might then say, what do we all give these highly conformal treatment fields? But the fact is that you can't buy a machine today that can't do this. And in my institution, where we've been using this for many years now, over 20 years, it's actually, that's what our dose planners and physicists are most familiar with. So that's what they will do. It's not complicated. It's simply that the machines and the algorithms for dose calculation have become so much more sophisticated. And I'm pretty sure that your radiation oncologists feel the same, that doing the conformal radiotherapy is the simple solution that they will use in most cases. In fact, I have to specifically ask if I want to use a more old-fashioned and treatment method. Normal fractionation, as I mentioned before, that means that we are giving the treatment in normal small fraction sizes that we are using for curative treatment traditionally to protect the normal tissues for long-term complications. And normal fractionation is a dose of 1.8 to 2 gray. That's what's normally defined. We will still use that. We use that mostly in our daily practice. First of all, in patients with life expectancies in the order of years, and also when we give radiotherapy concurrently with novel agents where we do not have firm safety data at the present. And that is particularly, of course, in sites where potential toxicity may be of concern. For instance, if the oral mucosa, the esophagus, large volumes of bowel and heart and lungs are included. And for Hodgkin lymphoma, even in the setting of multiple relapses, patients may have life expectancies in the order of years. This is particularly true now with novel targeted therapies. And for these patients, radiation therapy can provide effective palliation of symptoms. Radiotherapy can provide also a treatment break from systemic therapy if the patient is sort of having feeling much of a burden from the treatment. Then you can have a break and just use radiotherapy to keep the disease at bay. Even modest doses, for instance, 15 gray, which is a very small dose, are associated with actually moderate, but some local control about the order of 50%. And if we use relatively low doses like 20 to 30 gray in 5 to 10 fractions, then that will offer in many cases quite long-lasting palliation of symptoms from the disease. And for patients with limited disease and good prognosis, aggressive palliation with doses up to 40 gray may be considered. In fact, 40 gray is above the dose that we normally give to any patients with Hodgkin lymphoma. And we tend to do that in a situation where the patient has multiply recurrent or refractory disease. But actually, it is unclear in general if chemorefractory disease is less sensitive to radiotherapy. There are no good data on that. So probably, as far as we know, we don't need to go to higher than normal lymphoma doses, which are modest by a radiation oncology perspective. In solid tumors, the doses that we give, as you probably all know, is about over 60 to 70 gray. So the doses are still much lower than we would use in solid tumors. For Hodgkin lymphoma patients, when you want to use radiation therapy for palliation, you need to remember that there are several systemic agents that are associated with pulmonary toxicity: bleomycin, brentuximab, gemcitabine, nivolumab, pembrolizumab. All of them are associated with some pulmonary toxicity. With regard to both bleomycin and brentuximab, there's enough experience that we know that chest irradiation after these drugs has not been associated with an increased risk of pneumonitis. We have less information available on nivolumab and pembrolizumab, but we have seen no increased risk in solid tumors. So this is probably not an issue you need to be very cautious about. But if large lung volumes will be irradiated, then we would tend to advise to give fairly small fraction sizes, 2 to 2.5 gray, to minimize the risk of complications. For aggressive B-cell lymphomas, we know that relapsed or refractory aggressive B-cell lymphomas remain radio-responsive even when chemorefractory. And we have used, and I'll come back to that later, but very low doses in the indolent lymphomas and relatively low doses like 8 gray in 1 fraction, which is a good palliative treatment, or 20 gray in 5 to 8 fractions. They will actually yield overall response rates of about 80%. And more conventional doses will, up to 40 gray. 40 gray would be our normal dose for aggressive B-cell lymphomas with active disease, and will yield responses almost certainly, but the durability of local control is somewhat modest, median 12 to 18 months, but that may also in many patients be worthwhile. And shorter if the patient has bulky disease. What we also know is that the presence of c-MYC, BCL2, and/or BCL6 gene rearrangement doesn't seem to influence response to radiotherapy. So double or triple hit situations are not causes for changing radiation therapy and not causes for doubting the effect of radiotherapy. They respond equally well. For relapsed or refractory CNS lymphoma, they may have active symptom control with whole brain radiotherapy with doses of 30 to 36 gray, sometimes lasting for months or even up a year or something like that. Sometimes quite surprisingly how long these patients last. It's obviously not a curative treatment, but it may offer palliation for a significant time for these patients. And this is just an example of a patient with diffuse large B-cell lymphoma stage 4, diagnosed in 2019, treated with the 6 cycles of R-CHOEP and 2 series of high-dose MTX. He achieved a complete metabolic remission, but it was short-lasting. In February 2020, he progressed. And he refused more chemotherapy, started experimental treatment with a bispecific antibody in March 2020 and achieved a mixed response. Continued treatment until March 2021, where the lymphoma progressed in the initially bulky disease in the left side of the retroperitoneum and around the left kidney. So he stopped the experimental treatment. There was no other experimental protocol available, but the patient was on a waiting list for the next phase 1 trial that we could offer in our clinic. And so here you see the PET-CT scan in March 2021 when he was progressing with a large, highly FDG-avid tumor in the left side of the abdomen. We gave him radiotherapy, just 25 gray in 5 fractions, as you can see here, to a fairly large volume in the retroperitoneum, but it was given with the modern conformal technique. So it was actually very well tolerated. That has in fact been our experience with the COVID fractionation with the large fractions in lymphomas, that they are surprisingly well tolerated. That is simply because of the technique offers protection of the normal tissues to such a large degree. And here you can see his PET-CT scan in August 2021, where he had complete metabolic remission in the irradiated volume in the retroperitoneum. Could we change, please? Then in August 2021, he had progressive disease in the left side of his face, involving the left orbit and the left maxillary sinus, as you can see here. This is the PET-CT scan in August 2021. Then we gave him palliative radiotherapy to his recurrence volume here in the left side of his face, again 25 gray in 5 fractions. And here you can see his PET-CT scan in November 2021, again obtaining a complete metabolic remission in the irradiated volume. In November 2021, he progressed again, then in the left side of the neck, and he refused radiotherapy. And February 2021, he started R-GemOx, achieved a partial remission after 3 series, refused further chemotherapy, received experimental immune therapy in November 2022, and died in January 2023 with widely disseminated disease, but he never recurred in the 2 areas that had been irradiated. This is just to show you that with judicious focal radiotherapy, palliative radiotherapy at different points in time, you're actually able to keep these patients in a reasonable state. For instance, if you are wanting to bridge for waiting for some more fancy treatment like phase 1 studies and things, but also in the ordinary patient who just wants to prolong his or her life with a good quality of life as long as possible. For patients with highly aggressive B-cell lymphomas, radiotherapy may actually be given in twice daily fractions. That is what we call accelerating the treatment. And that is because in very rapidly growing tumors, it may be important to accelerate the treatment to counter the problem of repopulation, which is, of course, a significant problem in very fast-growing tumors. So this can be considered. We have used it in several instances for anaplastic for lymphoblastic lymphomas and Burkitt lymphoma in certain situations. We don't normally do radiotherapy for these the highly aggressive lymphomas, but in the palliative situation, it may be useful. A regimen that has become very popular in the States is the quad-shot regimen, where they give, for instance, 14 gray in 4 fractions over 2 consecutive days, then wait for a month, see if more is needed. It can be given 3 times at 1 month intervals. In that way, the patient needs to spend little time at the clinic and has possibilities to use his or her residual lifetime in the best possible way. We have been using very low dose radiotherapy for indolent lymphomas, and I'll come back to that later. But in the aggressive lymphomas, the response rates are much lower. It has turned out that especially in the non-GCB diffuse large B-cell lymphomas, where the response rate is very low with the very low doses, whereas the GCB type diffuse large B-cell lymphoma seem to be much more responsive to the very low doses, which is an interesting observation, I think. But the very low doses are not suitable for situations with aggressive lymphomas where you need fast tumor control, where there's some impending effect that you would like to avoid. I would like to move to the next slide, but it seems not to work. Could I have some help with the next slide, please?
Mr. Kalpesh, if you can just move the slide from your end.
It somehow doesn't respond to my efforts.
Mr. Kalpesh, can you move the slide from your end? Yes.
Thank you. For a whole new field of using radiation therapy for lymphomas has come up with the CAR T-cell therapy. Bridging radiotherapy, which is given after leukapheresis but prior to CAR T-cell infusion, has been used increasingly and turned out to be safe. And because the production time of CAR T-cells is significant, then some of these tumors, which are generally chemo refractory, need to be kept at bay for the waiting time. And radiotherapy is a very effective modality for this. And it has been published and presented at meetings several times. The largest series so far published was published recently from the UK. The reference is here in the slide, where they used bridging with radiation therapy on 169 patients, which was 24% of all the patients that treated with CAR T-cell therapy. 129 had radiotherapy as a single modality for bridging and 40 as a combined modality. And they were pretty bad patients. 66% had advanced disease, 37% had bulky disease, 87% had elevated LDH, and 42% had an IPI of 3 or larger, and 15% had double or triple hit lymphomas. The median dose was very variable. This was done on an individual patient basis at the many different centers in the UK. The 1-year progression-free survival for patients who were bridged with radiotherapy alone was 56%, which was pretty good. You can see the survival curves and the progression-free survival and the overall survival curves down here. And the full red line are the ones who have been bridged with radiation therapy alone, and they seem to be doing pretty well. Now, obviously, patients who are bridged with radiation therapy are generally patients who have fairly sort of localized disease, whereas patients with widely dispersed but not in themselves large tumors are not that suitable for radiation therapy. So there is some selection bias in this, but at least you can see that the patients bridged with radiation therapy alone fare pretty well. the impression the British group gets is that the cytoreductive effect of bridging therapy and the effect of the tumor burden pre-CAR T infusion are really more relevant than just how much the patients respond to bridging therapy. And this is a very interesting point. In fact, the British are finding that they are using radiation therapy more and more, not just to bridge patients, but to achieve cytoreduction, to achieve debulking. And I need to move forward the slide again. I don't know why my control buttons are not working. Could I have help to get the next slide, please? Fine. And this is an example of exactly this. Is a 54-year-old male with primary refractory double hit DLBCL, initially stage 3 with bulky disease in the abdomen. And he was treated with dose-adjusted REPOC, 21-day cycle and high-dose RRC, and ended treatment in January 2024. An interim PET-CT scan had showed complete metabolic remission, but the end of treatment PET-CT unfortunately showed progression in the abdomen as it was growing fast. So he was apheresed, and then he had radiotherapy, 25 Gray in 5 fractions to the bulky tumor in the abdomen, as you can see here in different planes. Again, this is a typical location of these bulky masses, and it's a pretty large tumor volume. But as you can see, it is not a very large volume that gets the full dose. It's only what is really needed. And he tolerated the treatment excellently. And then he had his CAR T cell infusion in April of this year. He went on to have cytokine release syndrome grade 2 and ICANS grade 3, but overcame all this. And his PET-CT scan here in June 2024 showed complete metabolic remission. So far, a success story. I don't have a very long time of follow-up on CAR T-cell patients here from Denmark, because we've actually only just now been allowed to start using CAR T-cells, which is extraordinary. But that's another story. Next slide, please. Mantle cell lymphomas are highly radioresponsive, and very low dose radiotherapy, just 4 Gray, which is a almost homeopathic dose in radiation therapy, given in 1 or 2 fractions, yields overall response rate of 80 to 90%. So that is very nice. It's been demonstrated that the rates of complete remission are not impacted by ibrutinib refractory disease, blastoid histology, or number of prior lines of chemotherapy. The local failure rate is high, 48% after a median time of 10 months. 4 Gray in 1 to 2 fractions may be a good option for patients with poor performance status and/or limited life expectancy. And if you have given 4 Gray, you can give additional radiotherapy. You can give that several times because it's such a low dose. But higher doses, for instance, 30 Gray in 10 to 15 fractions or 20 to 25 Gray in 5 fractions, should be considered in patients with good performance status and a life expectancy, a good life expectancy. They are associated with local progression in over 30% of cases. It is not a definitively curative treatment, obviously, but it does offer significant palliation, and it can be repeated in many instances, especially these. We always remember that you can always repeat it in another location in the body. So having had radiotherapy once certainly doesn't preclude having it again. It can be used actually several times. You need to work closely with your radiation oncologist to do this, because you need to, in some cases, simply make a new plan, see how much it overlaps with the previous ones, and from that judge whether you can give more radiation therapy. It is a very potent treatment modality also in mantle cell lymphoma, and should certainly be kept in mind. Next slide. For the indolent B-cell lymphomas, that is follicular lymphomas, marginal zone lymphomas, and small lymphocytic lymphomas, or CLL, the situation has changed quite dramatically in the last years. These diseases are exquisitely radiosensitive, and 4 gray in 2 fractions yields an overall response rate of 80 to 90%, which is quite durable with a median duration of about 17 months or something like that. And this is regardless of the number of prior lines of systemic therapy and regardless of age. The responses may be seen as early as a few days after treatment, but the maximal response may come after weeks to months. So you should never evaluate the final result of radiation therapy. That goes, in fact, in general, before at least 2 months have elapsed since the patient was treated. We know from large randomized trials of the British group that the local control is slightly higher if you give 24 gray in 12 fractions, still a very small dose and still a dose that is associated with very few side effects. But 4 gray can actually be given in 1 fraction. We showed that during the COVID pandemic. It is included in the ILROC guidelines that I mentioned to you previously, which you can find in blood. Having used that dose, you can retreat and achieve responses again. So this is a way where you can keep the disease at under reasonable control and with good palliation for many patients. And next slide, please. Here is an example, actually, from my patients during the COVID pandemic. The patient had a follicular lymphoma stage 1 in the right axilla, so this was curative treatment. And you can see to the left here the PET-CT scan before treatment with a highly FDG-avid lymph node in the right axilla. The patient was treated actually with an old-fashioned technique. In this situation, this was better because it spares the lung better. And as I said, had to ask specifically to get this old-fashioned technique. 4 gray in 1 fraction, just 1 treatment, very convenient for the patient, and the PET-CT scan 3 months after treatment showed complete metabolic remission. So this is really a game changer in the indolent lymphomas. And next slide, please. Could I have the next slide, please? I don't seem to be able to control it from my computer here. Yes, the reason is that indolent lymphomas, actually all lymphocytes are very radiosensitive, but the indolent ones, they are apparently fairly similar to normal lymphocytes in this respect. They are exquisitely radiosensitive, and even this low dose of just 4 gray in either 1 or 2 fractions activates the p53 pathway and leading to apoptotic cell death. And this is a study done by a good colleague in Amsterdam, Rick Haas, where he did a fine needle aspiration from a lymph node before to the left and after. This was actually after just 2 gray. And what you can see to the left, there are lots of viable lymphoma cells, and to the right, just after this tiny dose of radiation therapy, you see massive nuclear chromatin condensation and apoptotic body formation, demonstrating that these tumors are programmed to go into apoptosis if their DNA receives the slightest DNA damage, which may be very convenient from the body's perspective. And this is what happens. Oh, you changed, right? That's okay. I'll just also mention another type of palliative treatment that you should remember. And this is, again, to remind you that for a medical oncologist or hematologist, there are parts of the lymphoma spectrum that you rarely see, and where the experience of a medical oncologist or hematologist may not be as broad as in normal lymphomas. And the cutaneous lymphomas are one of them, because they're treated in my country mostly by dermatologists, as long as they remain localized to the skin, which they do for those patients for all the rest of their lives. And the most common one is mycosis fungoides, which is a cutaneous T-cell lymphoma, which is usually disseminated in the skin, but rarely to other organs or to lymph nodes. So for these patients, skin-directed therapies are important. They are incurable, but when the dermatology treatments are no longer effective enough, if the lesions get thicker so that the treatments don't work, then again, as for all lymphomas, radiation therapy is the most potent treatment modality, the most effective treatment modality for achieving local control. And in this situation, with widespread disease, we can do total skin electron beam therapy, which enables us to treat the whole skin to a dose. Actually, in the old days, we did 30 gray, quite a significant dose. The technique is pretty demanding for the radiation oncology department because we actually irradiated about 25% of the body mass to a dose that is far above lethal dose if you gave it to the whole body. But it's possible to do with electrons. It's a small negatively charged particle. It's eminently suited for treating superficial lesions. And just might want to mention that this is a palliative treatment, but a palliative treatment that is able to keep these patients in a reasonably comfortable and asymptomatic condition for a very long time. These are very indolent diseases. The patients live with them for years. And this, again, is a special way of using radiation therapy to achieve palliation for these patients. If you can see the next slide. They respond very well, and you can see here what happens, that before total skin electron beam therapy, this patient has plaques and patches all over the body, itching and so on. And after radiation therapy to the whole skin, we achieve a normal skin structure. There's some discoloration, which will then bleach off for the following year. So another fairly special way of using radiation therapy for palliation of lymphomas. And incidentally, electron beam therapy is eminently suited for treating all cutaneous lymphomas, both the ones that you can cure and the ones that you can't, as this one. So next slide, please. So in general, if you have cutaneous T-cell lymphomas, remember these should be primary cutaneous T-cell lymphomas, that is, they should be treated with skin-directed therapies as long as they are located to the skin, which they usually are for most of their presentations. And they can be treated with electron beams, which are, as I said, eminently suited for superficial lesions. And for local disease, doses of 8 gray in 1 to 2 fractions yields a 90% complete remission rate. It's completely free of side effects and very easily done also from the patient's perspective with very few treatments. Next slide, please. Some of the cutaneous B-cell lymphomas are also very indolent, and they also remain located to the skin in the vast majority of patients for the whole duration of the disease. And for focal symptomatic lesions, again, local electron beam therapy is useful, and 4 gray in just 1 to 2 fractions, as for the indolent systemic lymphomas, is a very effective dose. So very, very easily treated and can be retreated if recurring. So again, please remember, these patients should not be treated with systemic therapies. Next slide, please. Yes, then there's multiple myeloma, and I can tell you that I see more and more and more of patients with multiple myeloma, and that is because obviously the medical treatment of multiple myeloma has improved very significantly. And so these patients live longer, and consequently they also need palliation much more often, because still the disease is, of course, except for the solitary myelomas that are treated with radiotherapy for a curative intent, but apart from that, they are incurable, so they will sooner or later be in need of palliation. And radiotherapy is important for palliation of pain from bony or soft tissue lesions. And we see more and more soft tissue lesions again, I think, because the disease, the prognosis has improved. So the patients get to a point in their disease history where these soft tissue lesions start to appear. The pain relief that you get with radiation therapy from bony lesions may occur actually a few days after starting radiotherapy, but it also may only occur several weeks later. So we never know in advance who will respond quickly and who will not. So it's important to tell the patient that we cannot evaluate the full effect of the treatment until 2 months at the earliest. So there may still be a lot of benefit from the radiation therapy, even if it doesn't happen during the treatment. The pain relief may be related, of course, to a reduction in tumor cell mass, but it may also be related to a cytotoxic effect on osteoclasts, which are destroying the bone, and also inhibition of chemical pain mediators, cytokines, and so on, because the radiation therapy also destroys inflammatory cells in the area. Radiotherapy is, first of all, an effective treatment for spinal cord compression, and of course we see also more and more of those because the patients live longer. And surgery for spinal cord compression is actually only needed if there's bone instability or if there has been prior radiotherapy precluding re-irradiation. That may be the case. We see patients sometimes coming back with new spinal cord compressions in other levels, typically 2, 3, 4, 5 times, or if there are bony fragments that cause cord or nerve compression. And in fact, we have a service at our hospital where these patients are seen in the acute ward by our senior registrar, and if deemed relevant, if the patient is not in a too poor condition, the spine surgeon will see the patient also and judge whether surgery can be done. And it can be done and should be done in some cases, as mentioned here. But in most cases, it is not possible, simply because a stabilizing operation will need some solid bone for the material for the screws and so on. And in many cases, as you very well know, the patients do not have sound vertebrae that can be used for fixating the instrumentation they need for stabilization. And what is important to remember is that unless radical surgery was performed, and that is very rarely the case because that's a major operation, then post-operative radiotherapy should be given to improve local control. Otherwise, sometimes forgotten, we see that when the patient has been transferred then to another hospital and people forget after the operation, and people forget that they should also have radiotherapy. These operations are not radical, so there are remaining tumor cells in the operation area. So you need to give radiotherapy. Otherwise, the patient will most likely come back a month later with a new spinal cord compression. So, again, please, new slide. For multiple myeloma, the doses are again in the small to moderate area. 8 Gray in 1 fraction is actually an excellent pain control in a situation where there is no impending fractures or anything. Otherwise, we tend to give higher doses to achieve better tumor control in the area if there is an impending risk of fracture. 20 to 25 Gray in 5 to 8 fractions or 30 Gray in 10 fractions are all effective with an 80 to 90% overall pain response. And some studies do indicate a longer duration of pain control with higher doses, which isn't so surprising because you do achieve better tumor cell control with the higher doses. For spinal cord compressions, there is a trend towards higher local control with long course treatment, that is 30 Gray in 10 fractions or 40 Gray in 20 fractions, which we actually use for patients with newly diagnosed disease who are candidates for stem cell transplant. compared to short course radiotherapy with 8 gray in 1 fraction or 20 gray in 5 fractions. So for patients with a good outlook with regard to survival, then a longer course may be advisable. For extramedullary disease, again, we use the traditional fractions of 20 to 25 gray in 5 fractions or 30 gray in 10 fractions. They are used for palliation of symptoms, and in this situation, obviously, the symptom relief will rely on adequate tumor shrinkage, so a slightly higher dose will ensure that with a higher degree of likelihood than 8 gray just in 1 fraction. For pathologic fractures, surgical stabilization is recommended because obviously radiation therapy will not change the position of the bones. So some stabilization is giving a better position of the bones and also making healing more likely. And this is just a case of extramedullary disease. We see more and more of these, and they can grow to quite astounding sizes. This is a very young patient with a bone lesion in a rib, which has then extended into the soft tissues. This patient was so unfortunate that they extended mostly inwards. So this was not actually diagnosed until the myeloma looked like this, taking up most of the right lung. And I can't see the lower part of, but this was before we started radiotherapy. And this is the treatment plan we started on. And you can see that I can't really see how long it was up, but there's some, you can see it hopefully. And then you can see what it looked like after, I think it was 10 fractions. These patients actually warrant following. We do daily imaging of these patients, and this myeloma, and I've seen that in many other instances as well, with these big myelomas, they shrink during treatment. And so we had to re-stimulate to decrease the target volume to protect the lungs around it, because it really shrunk significantly during the treatment. And it has not recurred, I think, a couple of years after. So it achieved, radiotherapy is able to achieve very good local control in patients with multiple myeloma. And next slide, please. Can I have the next slide? The next, please. We saw that just now, so I need the next slide. Yeah, well, actually, you're right. Could I have that form, because it was pretty impressive. Could I have the former slide, the one before? Because this actually shows that this is what it looked like 2.5 years later. Really, as you can see, a very significant and actually very durable local response. So next slide, please. Thank you. When you do multiple myeloma radiation, volume should be limited as much as possible to spare residual marrow function, of course. And for this, again, the modern techniques are so much better than in the past. So what you have of experience from 10, 20 years ago doesn't apply anymore, because the highly conformal radiotherapy has meant that the side effects are much smaller. For spine lesions, we will always include the entire affected vertebral body, because otherwise there might be a recurrence. The bone marrow in that area is, of course, contiguous, so it might happen. And it's very difficult to irradiate again if you have an irradiated part of a vertebra. For long bone lesions, it's sufficient to treat the affected area. You don't need to irradiate the whole bone. For instance, if it's a femur, you don't have to irradiate the whole bone, just the area with some margin, 2 or 3 centimeters from a fracture or an impending fracture, but not the whole bone. For femoral neck lesions, the femoral head should be included, and that is because a retreatment would be very challenging. And for patients who have undergone surgical fixation, we will only try to cover the hardware if it is very localized. If the hardware including all the hardware would mean a much larger radiation volume, then only treat the diseased bone, not trying to cover all of it. We do know that there are myeloma cells also in probably in other places, but of course these patients have disseminated disease anyway. So and we're not going to cure that. So don't make excessively large radiation volumes. And next slide. This is then just an example of a patient with multiple myeloma with a spinal cord compression at the L1 area, as you can see. And this is just to show you what a radiation volume looks like today. This patient had, as you can see, not only involvement of the vertebrae, but also on the surrounding soft tissues. So we had to extend the volume somewhat to the right to encompass the soft tissue lesion. And as you can see, this is located at the level of the lungs and the heart, but the full dose is only given to the vertebra. So the toxicity is really minimal. This was at diagnosis, and the patient was a candidate for stem cell transplant. So we gave this a small fraction treatment, 40 gray in 20 fractions. You can do that and still give the systemic treatment that you would normally give as a part of the treatment of a newly diagnosed patient. We usually give VRD, and that can be done concomitantly without any risk of side effects. Next slide, please. We have a situation now that I find very interesting. You know, in solid tumors, we are talking a lot about oligometastasis, few metastases from solid tumors, and if they are irradiated, it can actually significantly improve patients' survival. And I find this situation with oligomyeloma very interesting. If you have just a few sites, 1 to 3 sites with active myeloma seen, for instance, on PET-CT scans, which we use a lot, either at presentation or in many cases after systemic treatment of multiple myeloma, then what has happened in the patients who had systemic treatment is, of course, that, and we know that there is this clonal evolution in different lesions in multiple myeloma in 1 or a few sites. And then radiotherapy is, as I said, very effective. It can virtually always control local disease. So what we often do in collaboration with our hematologists is that we give radiotherapy to the few active sites, which may then allow the patient to continue with the systemic treatment that had brought the rest of the disease under control and which has been tolerable. So instead of having to change regimens, what we do here is that we give radiotherapy to the active elements, and the patient continues with the systemic treatment that he's already on, and which has been effective for his disease and reasonably well tolerated. So this is a way, by collaborating and using the different modalities to in the best possible way, we may be able to buy the patient time and also quality time, which I think is really, really important. So next slide, please. Chloromas, focal acute myeloid leukemia infiltrates are rare extramedullary manifestations of leukemias. They again are not as rare as they used to be. And that again is because the survival of patients with AML, ALL, or CML or MDS has become much better, and they can occur anywhere in the body. I've seen them just about anywhere, I think, but it's most often in bone and soft tissues, and they are also rate responsive. And the response rates are high, about 90%, with modest doses of 20 to 26 gray. We usually give 24 gray for these. And this is the recommended dose, 20 to 24 gray in 10 to 12 fractions in the guidelines. We made special guidelines on chloroma, which you can all find if you search ILWOC guidelines. And if they are elderly and frail, what we did develop for the COVID fractionation schemes is just 12 Gray and 3 fractions, which is a very easily tolerated treatment for these often quite debilitated patients. So this is an effective treatment for localized chloromas. And next slide, please. One particular situation in acute leukemias is that you can see the skin lesions, the chloroma cutis, as it's called. And this is an 84-year-old man with newly diagnosed AML in February 2022. He had sort of very indolent causes, less than 20% blast in the marrow, and he had myeloid sarcoma in his skin biopsy. This is from the scalp, where he had a large lesion, and they had been present for a year, so it was a sort of fairly odd indolent cause. And the patient was offered Vidaza treatment, but declined. So he received local electron beam therapy, and again, in the skin, electrons are particularly well suited. He got the COVID fractionation of 12 Gray and 3 fractions and achieved a complete remission. I unfortunately don't have a picture of this, but next slide, please. He came back with generalized lesions. Yes, please, the next slide, please. And as I mentioned, for focal lesions in the skin, that's what he had, and at the first time, good remissions are achieved with just local electron therapy. But for more disseminated leukemia cutis, then we can use the same technique as we used for mycosis fungoides, namely to give total skin electron beam therapy with a clearly palliative intent, but with CR rates of about 50%, PR rates almost the same. And you can give 12 Gray in 6 to 12 fractions or 12 Gray in 3 fractions with just 1 fraction per week. And next slide, please. This elderly gentleman came back with more disseminated chloromas in his skin. You can see here these lesions to the left. Before he was treated, they popped up everywhere, and it was pretty symptomatic for him. So we gave him total skin electron beam therapy. We gave him the short fractionation with 4 Gray just 3 times with 1 fraction per week. So easily tolerated even for this elderly gentleman. And to the right, you can see the result. All the infiltrates in the skin evened out, and what remained was just some discoloration. The patient's condition obviously deteriorated. He had acute myeloid leukemia. He died January 2023, but he never progressed in the skin. So again, this was very effective palliation for this patient and for several other patients. Again, it is they are seen more commonly these days when leukemia patients live so much longer. Next slide, please. So the conclusions. Radiotherapy is an important treatment for palliation in hematologic malignancies. It's effective even in multiple relapsed or chemorefractory disease. Historically, radiotherapy was used when no other systemic options were available, but the role has recently expanded as a bridge in debulking to potentially definitive treatment. The lowest effective dose should be used with consideration of the goal of the treatment. How long remission are we expected to need in this patient? That depends very much on the prognosis, the site that is involved, the patient's performance status, the previous irradiation the patient had, and concurrent systemic therapy. We want to give the fewest fractions possible to achieve safe palliation, to minimize the burden of visits for the patient, and to minimize the treatment break from systemic therapy. And I just, from the excellent introduction or starting introductory address, I would just remind you that apart from all these things, radiotherapy is very inexpensive. It's a very inexpensive treatment. So instead of considering some extremely expensive drug, if you can use radiotherapy, that would be much less expensive for your system and for your patients. So with this, just yes, let's see the next slide. I just remind you of the International Lymphoma Radiation Oncology Group. And if you are not doing radiation therapy, then please remind your colleagues back at your institutions on the ILROC. It's completely free to become a member. Just join by going to our website or contacting our administrator, Beatrice Regonese in New York. And you get access to our website and to a lot of interesting information. And the last slide. Thank you for your attention.
Thank you so much, ma'am, for that wonderful talk. It was quite impressive. You covered almost all the aspects of hematological malignancies. So we are in the new world of radiation today, I think so. Thank you so much for that wonderful and fabulous lecture. That was fantastic. I request all our discussants to please put the raise hand sign so that we can start our question and answer session with Dr. Lena Speck, ma'am. Yes, Dr. Yeah, please go ahead.
Yeah, hello.
Please go ahead, yeah.
Any experience with CXCR4 based endotherapy in hematological malignancy, especially with yttrium or lucium?
Sorry, I didn't quite get the question.
Any experience with CXCR4 based endoradiotherapy in myelomas and lymphomas?
I'm not familiar with the abbreviation. What did you say, CX?
It is CXCR4 based, CXCR4 tagged. They tag the CXCR4 molecule, and if it is positive, they give endotherapy with this molecule, especially in tumors which are extramedullary tumors. They have been tried in myelomas and some solid tumors.
Oh, what is the name of the drug? Is it radio immunotherapy or something like that?
It's a radioimmunotherapy, yes.
Yeah.
Yttrium or lucium based, CXCR4 tagged. They use this CXCR4 molecule in this.
Yeah, I may not be familiar with the abbreviation, but I can talk about radioimmunotherapy. No, we have no experience with it. I don't know what the isotope is that is on this molecule. Do you know?
It's, I think, yttrium or lucium they used. Lucium?
What?
Lucium or atrium?
Oh, lutetium. Yes.
Lutetium.
Yeah. Well, we haven't tried it. In general, radioimmunotherapy for indolent lymphomas has actually been quite effective. It has not really gained any widespread use, and I think that is partly due to poor marketing. But we don't have much experience with this. It has sort of died out with the indolent lymphomas, and I have never tried it with multiple myeloma. It is also always a question how much, if you have a very extensive disease with multiple myeloma, the question is this just a sophisticated way of giving total body radiation?
Yeah, it's kind of a, it's a CXCR. First, they do a scan with CXCR4 molecule, and patients who take this molecule, that is CXCR4, especially tumors which are, extramedullary tumors. So these extramedullary tumors are then targeted by this lutetium-based endoradiotherapy. They call it endoradiotherapy.
Yeah, I know lutetium treatments we use it for neuroendocrine tumors and things like that. You have to realize that you will never get close to the doses that you can give as external beam radiotherapy. So if you have just one or a few lesions that you need to treat, then you will get a much more effective treatment by giving external beam radiotherapy with the highly conformal techniques that we are using these days. It could be a choice, I guess, but I have no experience with it if you have more widespread soft tissue myelomas. But please remember that with these treatments, you will never get to doses that are nearly as high as the ones that we get with radiation therapy. I've used isotopes a lot with treating thyroid cancer, and in thyroid cancer, you do get doses that are actually above the doses you get with external beam radiotherapy. But that is a very, very special situation where the iodine is concentrated so very efficiently in the gland. For the others, the concentration is not giving you doses that approach the doses that you can give with external beam radiotherapy.
Thank you, ma'am.
Thank you so much. Dr. Sangeeta Kakoti, your question, please.
Thank you, Professor Speck, for your very enriching talk. So I have one comment and two questions. The comment is, as you showed in that case, so I'm a radiation oncologist. So when we get patients who are sent for palliative radiotherapy, but if they have localized disease and with general condition, we do the same that you have shown, like hypofractionated, but up to biologically curative doses, and we have seen very good results. We'll analyze and publish soon. And I think we should, that was nice to know that that is also recommended by you. So my questions are two, which we see in the clinic. Number one is, sometimes we get patients of CML who have symptomatic splenomegaly, and they are referred for palliative radiotherapy. And they very often have very low platelets. So I just want to know about your dose and fractionation in those patients. And my second question is, sometime again, DLBCL stomach patients, normally they are started on chemotherapy, but they still have persistent melena. And then we try any, endotherapy, or we try to look for any bleeder, which they do not have. So we have to intervene in between by giving doses of, normally we prefer to give a single dose just to stop the bleeding, and then proceed again with chemotherapy. So I'd like to know your protocol in that situation as well.
Thank you very much. Actually, you're right. The splenic irradiation, I should have included that. In patients with splenomegaly from chronic myeloid leukemia or myelofibrosis, they are the largest spleens we see, and they can be massive, and they are massive because of extramedullary hematopoiesis. So most of the patients' hematopoiesis is in the spleen. There's also the problem that blood cells are sort of segregated and kept in the spleen. So the spleen both makes the blood and it also keeps it from entering the circulation. So spleen is doing both good and bad here, and it is very, very difficult to know what happens when you irradiate, whether it is going to benefit the patient or not. And you need to be very, very careful, because otherwise you will run into cytopenias because you are irradiating the patient's hematopoiesis, really. And quite often it's always the thrombocytes that give you the most problems. And as you say, very often these patients have thrombocytopenia already when you start out. So what I do is that I give very small fractions, because I know that I will probably have to stop the treatment before I get to the dose that I actually prescribed. I normally prescribe a dose of 10 gray, but in 20 fractions. So I give half a gray per day. And then I check the hematology, the parameters, hematologic parameters, twice, sometimes 3 times a week, because as you very well know, the effect of radiotherapy continues after you stop. So you need to, like, a super tanker, you have to stop way before you actually need to really stop. And so when I get to a thrombocyte count below 50, I would usually pause. And usually that happens when I'm halfway through the treatment, and I very often do not get any further. But that is also okay, because it has already given the patient palliation. They all often have pressure symptoms. They can't eat because this spleen fills up the abdomen. And so that's what often happens. And then they come back some months or next year or something like that with the same problem, and I can re-irradiate because I've only given a very low dose. So that's my policy. Then the situation you mentioned, when they already have thrombocytopenia, then that's really a matter of very individualized decision making. very often what I do is that I irradiate the spleen. I follow the patient very carefully, also with the hematology values, and we see how far we can get. But this is really where I don't think you can give any rules except that be very careful and be cautious and stop before you've made any serious accidents. But it's a question. There's a syndrome of hypersplenism where the blood cells are segregated in the spleen. It's quite often also significant. So sometimes it gets much better, sometimes it doesn't, and you can't predict it.
Yeah, sure. Thank you.
And the other question was, that was the stomach. I think,
Stomach
yeah,
who have
we must-
persistent bleeding despite starting on chemotherapy.
yes. Now, diffuse large B-cell lymphoma, if that is a newly diagnosed case, they are bound to react to the chemotherapy as fast as for radiotherapy. So what we do is that we continue the chemotherapy and then irradiate them after they've had their chemotherapy. And I don't know that you can achieve faster tumor response by doing radiotherapy than chemotherapy. So I would actually continue the chemotherapy and transfuse the patient until.
Despite continued bleeding after starting chemotherapy, I mean, that is the only rare situation when we intervene sometime with just a single fraction of radiation just to the stomach, just to stop the bleeding, and then we proceed.
Well, I haven't seen any studies of this comparing them. I don't know what is best, but
Sure.
this is a case where you want. Well, actually, the problem is that if you irradiate a big tumor and you get response, then you leave a hole and it bleeds. And I guess it does that whether you use radiation therapy or chemotherapy. And these patients respond so well to the initial chemotherapy that I don't think you get a faster or better response with radiotherapy. So I think we haven't had the problem very often. We don't see very many diffuse large B-cell lymphomas in the stomach. We mostly see mortal lymphomas, and they rarely pose any problems. So I'm sure you don't do any harm by doing it. I'm not sure that it is any better than just continuing the chemotherapy and transfusing the patient until it's over.
Okay, thank you so much.
Thank you, Dr. Sangeeta. Dr. Sumit Mirk, your question, please.
So am I audible?
Yes, please go ahead.
Thank you for the excellent talk, Dr. Speck. I had a couple of questions. I am a hematologist, and the first question is regarding stem cell mobilization. So,
sorry,
in our experience,
the connection is a bit bad. Could you speak slowly and clearly?
okay. The first question is regarding CD34 peripheral blood stem cell mobilization. So, in our patients of lymphoma and myeloma who have received some form of radiation to the actual skeleton, like the vertebrae, that when we collect their stem cells, there is an issue with respect to the stem cell yield, and they require more plerixafor for stem cell collection. So I wanted to ask if you have faced this in your practice, and if there is any specific dose or at which it starts affecting the stem cell collection, the radiation to the actual skeleton. And if it actually does, then is there any time duration after which we should collect the stem cells in such patients so that the effect of the radiotherapy on maybe a post stem cell collection will fade away or lessen?
Actually, the bone marrow is very radiosensitive, and even doses as low as 2, 4, 8 gray will eradicate the bone marrow in the area where we are irradiating, and it doesn't recover. So you have to, and fortunately, usually patients who are candidates for stem cell transplantation are in the early phases of their disease, so they wouldn't have had much radiotherapy. We try to limit the volume that we are irradiating in particular with respect to not hampering stem cell transplantation. And the modern conformal techniques are certainly helping a lot in that respect. Also, in the old days, when we irradiated spinal cord compressions, we always took one vertebrae on either side just for safety. That was also because our image control wasn't so good. So it was sometimes, counting at one vertebrae wrong or something like that. We don't do that anymore. We do highly conformal radiation therapy. And I think we always think of limiting the amount of bone marrow that is included in the volume, because the bone marrow, as I said, is very sensitive. And you can see that years after they have been treating with radiotherapy, if you do an MR scan, you can see where the radiation field was done. In fact, we use that sometimes if we can't get the old simulation photos. We can actually just look at an MR scan and see where the radiation fields went. So no, there's really no good window. The trick is to try to limit the amount of bone marrow that you include in your radiation fields. Having said that, it is really not a very large volume. Even if we take several vertebrae, it's not a very large proportion of the active bone marrow that you're actually irradiating. So it shouldn't refrain you from giving well-indicated radiation therapy, but use techniques that are as bone marrow sparing as possible. I don't think you can fractionate yourself out of this. It is the bone marrow is so radiosensitive that even the lowest doses you could possibly use as a effective treatment will effectively eradicate the bone marrow in the volume that you're treating.
And as an extension to that question, do you believe that radiation to appendicular skeleton, for example, humerus or femur, should also affect stem cell collection?
Well, there are good studies of PET images of the active bone marrow, come from Melbourne. I think that's the one I've seen. So you can see where the active bone marrow is actually located. And if you're at the distal end of the femur or the humerus, there's no active bone marrow there. So that should not impair your stem cell collection.
Right. And if I have time for one more question, Dr. Amit.
Yes, please go ahead.
So we had a patient of primary mediastinal B-cell lymphoma who was treated 5 years prior elsewhere with chemoimmunotherapy followed by radiation to the mediastinal field. Now she has relapsed after 5 years and there is no response to the salvage chemotherapy. While we want some time to bridge her to CAR-T, do you feel that is there any role of repeat radiation in the same mediastinal field for either decreasing the disease burden or symptomatic release before she is taken for a more definitive treatment?
I certainly think there is, if she hadn't had that radiation therapy before. And to give radiation therapy in the same location, you will have to get the treatment plans from the institution where she had the treatment before to see if there is room for any more treatment in that area. And this is a tricky situation. And what we normally do is that we, with modern treatments, and I don't know what they have used at the other institution, it is possible to actually fuse the images and transfer the isodose curves from the previous treatment to the present day images. And then you will be able to see what dose you can get away with. But if they have given what we don't give that radiotherapy that much to mediastinal lymphomas anymore, primary mediastinal B-cell lymphomas, if they're PET negative after chemotherapy. So we are not often in that situation, but you'll have to add the doses to see if you can get away with it. And there you may get in trouble with the spinal cord, depending on which treatment technique they've used. But usually that can be dealt with by the modern techniques. But what you can't really compensate for is the cardiac dose. And that would probably be, that would be a calculated risk. And you don't want to take too much of a calculated risk when you are actually applying a pretty effective treatment afterwards. So you could consider bridging her with some form of systemic treatment instead. But she was completely chemo resistant, so I guess that would not be a possibility either. they are usually quite bulky, and the recurrence here is also quite bulky, as I understand. So I would get the treatment plans from her previous treatment and see how much you can get away with now without exceeding to a large degree the constraints that you would normally use for cardiac irradiation.
Thank you.
Thank you, Dr. Sumit Met. Dr. Sudhir Reddy, your question, please.
Thank you, Dr. Speck, for that excellent presentation. I have one question. This is a real life case scenario where a 50-year-old male who presents with GI symptoms, evaluated and found to have non-Hodgkin lymphoma, diffuse large B-cell lymphoma, non-GCB type, K67 of 70%. He was given 6 cycles of R-CHOP with IT methotrexate because retroperitoneal lymph nodes were involved. So post 6 cycles of chemotherapy, PET-CT of CR, there is no evidence of disease elsewhere in the body. So 6 weeks later, the patient presents with low backache, severe pain, and paraparesis. Evaluation was done. CSF showed positive for lymphoma cells. PET-CT showed increased metabolic activity in the spinal canal from D11 to L5. So is there any role of palliative RT in this patient?
Well, this patient has primary refractory disease, doesn't he? And so he's a very bad situation. And in this situation, first of all, you need to consider, do you have any salvage treatment for him, systemic treatment, because he's not going to be cured by radiation therapy. So what is he going to have for his salvage treatment?
So, sorry, patient is in poor general condition, not able to receive any intensive regimens.
So he cannot receive any intensive. In that case, I would certainly irradiate the volume where you know that his symptomatic disease is coming from, and that is in the spinal fluid. So, have you any idea of the extension of his meningeal disease?
No, the MRI brain is plain contrast is normal. MRI spine is also normal. Only CSF is positive. No morphological lesions.
Okay. Very often when you have recurrences in the CNS, in the spinal fluid, what happens is that somehow it seems that they sink so that it's in the lower part of the spinal sac that you have the large accumulation of cells. So in that case, I would offer him some palliative radiotherapy depending on his symptoms, but probably focusing on his on the lower part of his spinal sac. But if you don't have any imaging showing his recurrent disease, it's only in the fluid, and then you'll have to go by his symptoms entirely. But knowing how these diseases behave, I would concentrate on then the lower part of the sac.
Sorry, only the lower part, or is there any role for craniospinal radiation? Because CSF being positive.
We have done craniospinal radiation in some patients, but if you do that, it is a massive procedure. It is toxic, and it will give you severe cytopenias because you're irradiating the whole. You can't avoid. Well, you can send him for proton therapy. I think this would be overkill because I really don't think that craniospinal irradiation is indicated unless you have further treatment options that will allow this patient to become at least a long-term survivor, at least having durable remission for a significant time. If for pure palliation, I think that this is far too much to subject the patient to with such poor prospects.
Madam, what if the patient is in good general condition? Radiotherapy versus systemic chemotherapy. Suppose if the patient is severely symptomatic but good general condition, what is your preference? Whether to go with chemotherapy or palliative radiotherapy followed by chemotherapy?
If the patient is in a poor condition with a short expected survival, is that what you are saying?
Good general condition. Suppose if the patient is in good general condition, is able to tolerate chemotherapy, radiotherapy first or chemotherapy first?
Chemotherapy first, definitely.
Thank you.
Thank you, Dr. Sudhir Reddy. Dr. Gopinathan, your question, please.
Good afternoon, ma'am. Thanks for the informative lecture. So this is again a real life case scenario. This was an early relapsed Burkitt's lymphoma. Like he's on first salvage. The only problem that we had is the systemic disease has gone away, but then he has just got a focal disease in right humerus. So in case if we have to irradiate, like what should be the dose for irradiation? And second, if we plan for an allergenic transplant in this patient because he was quite early relapse, we consider more of a chemorefractory disease. If we have to plan for an allogenic transplant, then how should we dose the radiation for current treatment as well as for, if at all we are using TBA, how should we dose that?
If you have a focal residual disease, is it biopsied?
Yes, ma'am. It is biopsied and it is proven to be Burkitt's.
Right. Then I would definitely use radiation therapy to achieve a complete remission. And there aren't that many good data on the doses, but I would dose as a aggressive lymphoma, which would mean 40 gray. And that dose will eradicate the bone marrow in the area that you are irradiating. So it's really, you don't need to consider it because there's no effective dose for Burkitt lymphoma that wouldn't eradicate the bone marrow in that irradiated volume. The good thing is that it's a very limited volume of the active bone marrow, so it shouldn't significantly impair your chance of harvesting that patient. I would definitely do that. Have I replied to the whole of your question, or there was something more?
Yeah, ma'am. This is, I mean, it is, if at all we are planning for an allogenic transplant, where if I have to use a TBI backbone, then how do we dose adjust between the current treatment dose and if I have to do almost 8 to 12 gray of radiation, then how do I schedule the doses for that?
Oh, you mean if he's going to have total body irradiation as part of his condition?
Yes.
And 12 gray would be typical, and you wouldn't need to consider that. You can give the dose to that area. But if, on the other hand, if you're going to do it, now this is actually peripheral, so that's not so difficult. But I quite often, regularly, I'd say, am in the situation where, for instance, a patient with lymphoblastic lymphoma or acute lymphoblastic leukemia has a large mediastinal mass, which is difficult to get into complete remission. And we then, for the transplant, we will give 12 gray as a conditioning regimen for a myeloablative allogeneic transplantation. That's what you're talking about, isn't it?
Yes, ma'am. Yes, correct.
And then we will say that for acute leukemias, we normally dose to 24 gray. Now, then we plan it so that we give 12 gray to the mediastinal mass directly before he goes into his total body irradiation for the conditioning of the myeloablative transplant, so that he gets in total 24 gray to his mediastinal mass, combined in the total body irradiation and the preceding local radiotherapy to the mediastinum. It takes some logistics because you need to, the chemotherapy of the patient will need to be slightly modified. It's usually not a problem for them, but to give the 2 gray times 6 to the mediastinum, and then the day you're finished with the 2 gray times 6 to the mediastinum, the next day you start your total body irradiation. So that maybe there must be no break between the local radiotherapy and the total body irradiation. In that way, you spare the patient side effects from a full radiotherapy to the mediastinum, followed by a total body irradiation, because you use the total dose that the patient gets from both the local and the TBI. So that's what I would advise, and that's what we always do. Need some planning, but it's doable.
Okay, right. So one more question, if the time permits, sir. I have one cutaneous epidermotrophic T-cell lymphoma, which is T3, N2, and M0. If at all, but the lesions are quite spread across. I mean, the axilla, it is in popliteal fossa and quite scattered on the backside of the trunk. So I did see your slides on radiation. How, I mean, it's a T3 tumor. It's more of an ulcerative lesion. So can we employ radiation in such cases, or chemotherapy would be the better choice?
Is it a primary skin lymphoma, a primary cutaneous?
Yes. Yes.
In that case, you must remember that chemotherapy is not very effective, and the as long as possible for cutaneous T-cell lymphomas, you should use skin-directed therapies, and for these extensive diseases which they usually are, and this is a tumors region is a stage 2B as far as I can see. The significant disease in this patient is in the skin. So, and if they're tumors, usually what the dermatologists have will not penetrate deep enough. So in that case, these are the typical patients that we see for total skin electron beam therapy. That's a very effective treatment, and the problem for you is whether it is implemented in your radiation oncology department or anywhere near, because you can see I do it for the whole of Denmark. It is a very specialized technique, both for the physician but also for the physicists. You're using electrons in a completely different way, and you're using your machines in a completely different way from what you're used to. So you have to have people experience in this, and it doesn't warrant setting up in every institution. You won't have enough patients to get experience with it. Now, I know that in India, your problem is not patient numbers, so you could really probably doing in many situations. I do total skin electron beam therapy both for Denmark and for Sweden, actually. So the patients come here for takes 2.5 weeks or something like that, and they move from the whole of Scandinavia, really. It is the best treatment, and you shouldn't move to chemotherapy. In fact, the systemic treatments that work with cutaneous T-cell lymphomas are usually quite something like more immunomodulatory. In fact, the drugs that work with the primary cutaneous T-cell lymphomas are usually more in the immunomodulatory way than conventional cytostatic chemotherapy. R-CHOP works very poorly, or R-CHOP, of course, but and it's usually given as single drug rather than combinations, because you get just more toxicity but no more efficacy by combining drugs. I have personally very good experience with gemcitabine as a single drug, which I can recommend if you can't get total skin electron beam therapy. And you can, of course, then, well, most machines can do electrons. So I guess that at least your radiation therapy department will be able to give localized electron beam therapy to areas that have not responded. But then you have to be careful that gemcitabine is radiosensitizing. So you need to have some interval between the gemcitabine and the radiation therapy. But the most efficient treatment you could get here would be total skin electron beam therapy. And I have no idea where you can get it in India. And don't use intensive systemic treatments if they're not.
Single agent gemcitabine is what, if at all we are not able to provide the facilities, the single agent gemcitabine, I'm getting good data as well as a good response from most of my clinical counterparts. So that's what we apply.
It's very nice, actually. If it's CD30 positive, pembrolizumab is anti-CD30. What is it called?
Brentuximab.
Yes, brentuximab. Brentuximab. I have also good experience with that, but it's pretty neurotoxic, and these are elderly patients, so that's a problem.
Sure. Thank you, ma'am. Thank you.
Thank you, Dr. Gopinathan. Ma'am, we have some couple of questions from the audience. Dr. Anu wants to know, she's practicing in UK, and she wants to know that if we'll end up some patients with spinal cord compression, and MRI is also in favor of some metastatic disease, and there is no diagnosis been done on bloods, then we need to organize for radiotherapy or surgical intervention. and we find it very hard out of hours in a biopsy unproven case as to whether to proceed for radiotherapy, and they will end up into going for neurosurgery, hoping to get a biopsy specimen. So irradiating after the surgery is also a bit problematic. And if we use steroids to buy the time, the diagnosis can be compromised. So can you please give the thoughts on this? What can be your algorithm if we come across with spinal cord compression with metastatic disease and no diagnosis has been done till now?
Yes, thank you very much. That's not an easy question to answer because it's a classical situation. I see a couple every week, and it depends on the situation. First of all, and these patients, I would always ask them, have you done a PSA, if it's a man, of course, have you done M components and immunoglobulins that can guide us? And if it's a young man, have you done HCG beta and the relevant hormone evaluations? And then if you have a scan, is there, for instance, as often the case, an obvious lung tumor? Have you examined the patient? Is there breast cancer and some of the usual causes of bone metastasis with spinal cord compression? And the problem is that whether they operate, well, then you ask the surgeon, can you operate? I would prefer that, but I will know that even if they operate, I will not have a diagnosis for another week or so because they have to decalcify the bone to get a proper histologic evaluation. So that depends on the clinical situation. If the patient has neurological symptoms over and above just pain, then you will have to carefully consider whether you can wait for a diagnosis or you have to institute treatment. On the other hand, I do have a case just at this moment where there is a soft tissue mass compressing the cord. They have operated, they have stabilized it. That's very fortunate. She doesn't have any neurologic symptoms. And it's almost 2 weeks now since she was operated, and the pathologists have problems with deciding the diagnosis. For this patient, I think it's safe to wait to have the diagnosis. We have a suspicion that it might actually be some infectious process. And you always have to remember that there are other causes for spinal cord compression than malignant diseases. So if your situation is doubtful, if you do have a suspicion that it might be something else, and then try to see if you can postpone until the final pathology results are available. But if you can't, then this is not a decision, of course, for the junior doctor. It is something that you discuss on a senior level, and you might then, in some situation, be forced to start radiation therapy, although you don't have a definitive diagnosis and you don't have any signs on your scans or your physical examination that there is a tumor anywhere, simply to avoid that this patient becomes paraplegic. So I can't give you an algorithm because I think it's a very, very individualized decision, which has to be done on a senior level, obviously. And I do irradiate patients with on whom I don't have a histopathological diagnosis. Sometimes it's so obvious from the imaging that this patient has a disseminated malignant disease when you've seen it many times. And I would dare to start. But for this patient, for instance, I think that I can safely, observing her carefully, but I can safely postpone radiation therapy until I have a definitive diagnosis. And I suspect that this might be one of the very few cases where this is actually caused by an infectious process, and the treatment will be directed at that, of course. So yes, it's a difficult situation. I don't think you can give any rules that will cover every situation. It's a clinical decision whether you feel that the indications of a malignant disease is so strong that you will start treatment, or that you don't think so, and you then observe and try to postpone the treatment until you have found either got a definitive pathological diagnosis from the operation or from the biopsy which you might have made, or that you find that the patient has some other lesion, for instance, a lung tumor, a breast cancer, that are outside the irradiation field where you can get a definitive diagnosis even if you start irradiation.
Thank you, ma'am. Dr. Asif Iqbal has a question. Any thoughts on radiotherapy to residual site after salvage chemotherapy to achieve complete remission and proceed to transplant?
We are relying heavily and perhaps also a bit too heavily on the results of PET scans. And if we have a PET positive lesion after full chemotherapy, then we actually first evaluate, has there been a very good response? It was just a very large tumor, very highly FDG avid. It has responded very well, but there is some residual mass. Then quite often we will wait for another month, do a new PET scan, and often it will be gone. It's a fact that if you biopsy, you will then, in these cases, find no malignant disease, but it's probably, I find it difficult to justify doing all these biopsies, because if they're negative, do I believe them? So what if it's safe, if the situation is sort of under control, there's been a very good response to chemotherapy, just wait another month or two to see if that was just a inflammatory reaction after the regression of a very large tumor. But otherwise, if there is a residual mass, if it's still PET positive after you've observed for a month or two, or if it's progressing, then I would do radiation therapy to that focus to get a complete metabolic remission before entering transplant, because I think that's very important for the result of the transplant, whether you have achieved as good a remission as possible before you enter transplant.
No, ma'am. He has also commented about this. They have done in couple of patients with residual disease in head and neck regions. The results pre-transplants were very great, but yet to find out the progression-free survival benefit post-transplant when given radiotherapy versus no radiotherapy to residual sites before the transplant.
So, do I understand this right? You have a head and neck location?
So mainly they were given for residual disease in the head and neck regions only, and the results were great pre-transplant. But what are the data post-transplant as per the PFS is concerned is debatable.
Yeah, well, we would again consider if have you achieved a complete metabolic remission or not. And we would not irradiate if you have achieved a complete metabolic remission. I don't think head and neck sites are any different than any other sites. It's just a common site. We only, if the patient has had full chemotherapy, we only irradiate if there is a residual PET positive disease.
No, ma'am. Thank you so much, ma'am. Another question from Dr. Du Yuen Naga. She has a question. She has a patient who has already received 15 grays of radiotherapy before chemotherapy with ARC dose adjusted EPOCH for primary mediastinal B-cell lymphoma as a palliative for his urgent thoracic compression. Now he needs a consolidated radiotherapy or a consolidated treatment in forms of radiotherapy due to PET positive at the end of treatment. How would he modify his treatment now?
Well, if there is residual disease, active disease on a PET scan, he needs full dose radiotherapy at this point in time, even though he's had 15 gray before. So this will be a challenge for the planning, but not an insurmountable challenge. You just need to use modern, highly conformal techniques. And I'm pretty sure that that is done all over India. The modern machines can all do this. And once you've learned the technique, and in fact, we are the Rapid Arc School also for India. So we have several Indian teams here for the so I'm sure they can do it. Otherwise, they would be able to find a clinic nearby which can do it. And it is possible, even if you've given 15 gray to the mediastinum, in virtually all cases, it's possible to give full dose, which would be 40 gray for active disease in the mediastinum, 40 gray in 20 fractions, and it should be possible.
Thank you, ma'am. Another question from Dr. Babita Sodi. For a localized disease, a small dose of radiotherapy of 2 to 3 gray is a really therapeutic effective as told by you. And secondly, if the higher dose is required, like you mentioned in whole body radiation, how much to give? And what are the toxicities we are expecting if already given small dose radiotherapy and now a higher dose is required now?
So you are thinking of indolent lymphomas where we give just the 4 gray, see if that is enough. If it isn't, we give 24 gray because if there has been a large break in radiation therapy, you can't just add the doses, but actually people do that. And I think that is also probably quite safe because we give 24 gray, then the patient will have had 28 gray in total. That is still a very minor dose, which is tolerated by almost any organ. And I don't think you can see any discernible toxicity from the 4 gray you gave before. So I think that's absolutely safe. The other thing is that we know from the British studies that 24 gray is as effective as 40 gray. So 24 gray is a standard. We know that 4 gray gives an effective, which is about 70% of patients achieve a complete remission with that. So it's only the last 30% that need the higher dose. And I really think that probably 24 gray is also too much. But I wonder if anybody is going to do a randomized trial of 20 gray versus 4 gray. It becomes really, really laborious to reduce the dose based on randomized trials. I think the general experience is that 20 gray is also enough. We just know that the optimal dose lies somewhere between 4 gray and 24 gray. Where it lies, we don't know. So, but I give 24 gray because I think if 4 gray wasn't enough, they need to have the evidence-based dose that is the optimal dose, and that's 24 gray.
Thank you so much, ma'am. Another question from Dr. Darshana Rane. In a case of primary mediastinal lymphoma, would you need to go for radiation therapy for residual known FDG avid nodes also post chemotherapy?
No.
That was a straightforward answer. Another question from Dr. Divya. What is the role of splenic radiation in primary myelofibrosis with massive splenomegaly who is planned for allogenic stem cell transplant?
Actually, if you're going to do a transplant, that would depend on how much tumor there is in the spleen, and probably there is a lot. I've actually not encountered that situation. We usually give splenic irradiation either to alleviate pressure symptoms from this massive enlargement or this hypersplenism where the peripheral counts are low, probably because of segregation of the blood cells in the spleen. And for that, I give that very fine fractionation that I mentioned before, and usually don't get to more than 5 gray or something like that. I also give splenic irradiation to lymphoma patients. And lymphoma patients who have splenic involvement are completely different from the leukemia patients because they don't have any myelopoiesis in their spleen, so you can safely irradiate it to just ordinary full dose. If you are aiming at a transplant for a patient with a very large spleen, then you should consider, is this tumor cells? Probably is, but it will be very difficult to irradiate without some significant toxicity. I guess if it's a myeloablative radiation therapy, you could do it. I have never encountered the situation where we wanted to do that, but it could certainly be a way of reducing your tumor burden.
Thank you so much, ma'am. Another question from Dr. Anura Kantak. What is your opinion on omitting the cranial irradiation in a pediatric CSF positive ALL patients who have become CSF negative at the end of induction and are now planned for TBI-based conditioning for allogeneic stem cell transplant?
I would not be the right person to answer that, because I leave that to our pediatric oncologists to decide. And they are using cranial or craniospinal irradiation less and less. So that would depend on their risk evaluation of the patient. And only for high-risk patients would we give cranial irradiation. We do it less and less, I must say.
Thank you, ma'am. Another question is, for a follicular lymphoma with only primary bone involvement, what would be the treatment approach? Radiotherapy or chemotherapy? And if radiotherapy, what is the dose? Primary bone involvement, the bone involvement is femur with some
Femur, and it's a localized, it's not the bone marrow?
only the bone involvement, not the bone marrow. The
Okay.
bone involvement.
That, if it's really, that is a stage 1E patient, and that is potentially curable with radiation therapy. So I would give local radiation therapy, and I would give a dose of 24 gray, because if it's not a very old patient, to give the highest chance of achieving a complete remission in that location, knowing full well that in 15 years' time, half of these patients will have recurred somewhere else. But this will, first of all, 15 years without any recurrence would be very nice. Have to take the problem then, if it happens, and there's a chance of cure. And I think I would treat that as localized disease anywhere else.
So, ma'am, 24 gray will be sufficient, or should we go for up to 45 gray? Because it's only the primary bone involvement.
Yeah, I don't think that there is any indications really in these days that there is a difference in sensitivity of bone lesions and other lesions. I think some of the problems that were seen was from the old days when kilovolt radiation was used, and where bone was kind of not easily treated. But today, I don't see any reason why you should, if it really is follicular lymphoma and not grade 3B by the old classification, then I would treat it as a follicular lymphoma, give 24 gray, and that's it.
Thank you, ma'am. Dr. Sumit Big, you have a question?
So am I audible?
Yeah, please go ahead.
So this is regarding one of my colleagues' case. He had a primary refractory Hodgkin lymphoma who did not respond to checkpoint inhibitors. And in his PET scan, there was disseminated disease with a big lesion in the lung, along with multiple other lesions which were not as big as the one in the lung. And he received radiation to the lung lesion while his checkpoint inhibitors were ongoing. And 6 weeks after that, he achieved a complete metabolic remission in all the lesions. So after radiation to that one lesion, he, along with the checkpoint inhibitors to which he was not responding alone, he developed a complete remission in all the lesions. So this was, we read, and this was some kind of an abscopal effect. And something like this has been described in myeloma a few days back by Dr. Sagar Lonial's group. So I wanted to ask about this interesting thing, and if you feel that this really works, because in myeloma, we don't have CAR T yet in India, or maybe not on a commercial basis. So can this be an option to patients who progress to multiple lines of treatment before for prolonging the survival?
That is a very interesting observation. My good friend Tim Illich in Manchester is really an expert on immunotherapy of lymphomas, and he says that abscopal effects are seen more rarely than sites of the Loch Ness monster. Frankly, it is. Yeah, it was a joke. It's that there are sightings of the Loch Ness monster, and they are rare, but abscopal effects are even rarer. It is so rare to see it, and you'd have to really look at the case. This is really a case of abscopal effect. Was it not just the case that there was not a complete remission by the checkpoint inhibitor in the lung lesion, and that the other ones were responding? Because if it's truly an effect where irradiation of one tumor led to a response in all the other tumors outside of the irradiated volume, then that is an abscopal effect, and it's so rare to see. It is a very, very long discussion because the radiotherapy is actually a very good inducer of immunogenicity in tumors. And it is wondered by many why it cannot be made to work. But all the trials that have been made in solid tumors have not demonstrated any effect. Now, why is that? It may be because there are so many complex effects of radiation therapy on the hematopoietic or on the immune cells. Some of them are beneficial, others are the opposite. So perhaps we simply need more research into the basic mechanisms of radiotherapy on the immune system to find solutions to target just the effects that are beneficial. And we aren't there yet. So if you've seen this effect, but I'm pretty, I'll bet quite significant sums on the fact that you won't see that again for a very long time. So I don't think it's something that I would rely on to try to treat other patients the same way. But it's an interesting observation, and you should, was it you or some colleague that had the experience? You should really look into this case and publish it, because there are so few truly well-documented examples of the abscopal effect. I do believe it exists, but it has so far been a disappointment. There was a lot of hype about it about 10 years ago in solid tumors, and we saw some very impressive images of these effects, but then it died out. So I'm very, I suspect that it simply doesn't pan out, perhaps because we don't know enough about the basic mechanisms. And if we get more research on this, and that is ongoing, then we may in the future be able to get the positive effect of radiation therapy without all the deleterious ones. We have worked quite a lot looking at lymphocytopenia during radiotherapy. And it is the fact that patients who are irradiated for whatever kind of tumor, and we examined it actually in solid tumors, not to confuse it with some effect on the lymphoma cells. And we have shown that if you irradiate patients, you get lymphocytopenia, which is quite dramatic, and it's long-lasting. Even a year after the end of radiotherapy, there's still significant lymphocytopenia. It hasn't returned to the normal value. And I've never really looked at lymphocytes during radiation therapy. I kind of thought they were unimportant, and it was the neutrophils that I needed to focus on. But actually, the lymphocytes are much more radiosensitive, and their turnover time is so long that whereas the neutrophils and the other blood cells revert to normal values very quickly, the lymphocytes don't. And it is very clear that, of course, the larger the volume you irradiate, the more lymphocytopenia you get, but also the number of fractions is important here, because lymphocytes are so radiosensitive, as I demonstrate with the images of the apoptosis that was induced in indolent lymphomas. They're so radiosensitive that even a dose of 2 gray will kill 90% of them in the irradiated volume. So giving radiotherapy in many fractions is actually a bad thing for the lymphocytes. So the hypofractionation that we have introduced also with the COVID guidelines may actually end up being a better option if we think of the lymphocytes, and if we think of the fact that for immune treatments to work, you need the patient to have some lymphocytes. So probably what we'll find in the future is that a hypofractionation, which is now possible in many more cases with the modern radiation therapy technique, combined with the fact that we want the patients to receive immune therapy that is going to work, and then we don't want to compromise the patient's lymphocyte count, will actually change radiation therapy to much more hypofractionation, fewer fractions, because it doesn't matter whether you give 2 gray or 4 gray, you still kill all the lymphocytes in the irradiated volumes. So the way you can protect them, and we showed that quite significantly, we have several publications on it, you should just search my name, you can find them, that number of fractions, even if you account for the volume that we are treating, the number of fractions is also very significant. The more fractions you give, the more lymphocytopenia. So that case you are mentioning here, I don't think you can deduct from that abscopal effects occur very often. But I do think that it is a very, very interesting research object, and that if that case really, if a thorough analysis of what really happened still shows that there must have been some abscopal effect, then he or you need to publish it.
Thank you.
Thank you, Dr. Sumit. Any other discussions? Has any other question? Well, so there are no more questions from the audience and no more hand raised signs. Well, thank you so much for that fantastic and lovely lecture, ma'am.
Thank you very much. And
Wonderful, fantastic water knowledge sharing session, ma'am, as well as we learned a lot from your lecture, as well as what a wonderful discussion we had.
yeah, I always have wonderful
Almost
discussions
all
with
of our
you.
doubts in the field of radiotherapy today, covering all the aspects of the hematological malignancies. Thank you so much for that fantastic, lovely, excellent lecture. And what a wonderful discussion.
Thank you very much. I enjoyed it as well. So have a good day, all of you.
Thanks a lot, ma'am. And I thank all our discussants as well as audience to participate in this webinar. Meet you next week, Saturday, Sunday, with another beautiful webinars. Thank you so much, ma'am, once again. Goodbye for now.
Goodbye.